pleasure to welcome and announce Dr. Cynthia Curry. Personally, for us as a family, she's been really instrumental in our journey to get us here. She has been the one who really pushed hard for the genetic testing for Daniel, and she's also been the one who connected us with other families. And without that, you can imagine we wouldn't be here today. So very welcome to Dr. Curry.
Thank you so much. It's really nice to be here and to meet so many of you and to see your wonderful kids and to learn from them. Let's see here. So I'm going to do a clinical overview, and I think I probably have to fly pretty fast considering our time constraints, but hopefully I don't know that there'll be time for questions afterwards, but let's see. Anyway, so as you've already heard, most clinical studies begin with a single patient. And that single patient was Daniel. So I first saw him at our Bakersfield Satellite Clinic in 2008. And he was just the cutest kid. He still is. Mild delay, short stature, small hands and feet. And we did what was available at the time in terms of genetic testing, and it was negative. So time passed, we had no diagnosis. We saw him several times in Bakersfield. He had short stature and was started on growth hormone. He developed anxiety. And then more time passed. And in 2015, he was re-referred for Williams syndrome. Now, I don't know how many of you have heard of Williams syndrome. Okay. But it has some remarkable similarities to Janssen-de Vries, particularly with respect to the anxiety, the hyperacusis, and some of the behavioral things. So it wasn't really, I thought, okay. So I thought, okay, well, we have some new techniques. Maybe this is something tiny within the Williams region that nobody has really found before. So we did exome sequencing. And sadly, it was negative. So, okay, all right, back to the drawing board. So the exomes were reinterpreted by the testing lab in 2017 after this paper appeared by Bert de Vries and Sandra Jansen and this cast of thousands. So we had a diagnosis at last, and it made a lot of sense. So then I think Marinda asked, well, what about this? And that's how many of my clinical projects have started. Like a parent says, well, what about this? What do you know about it? Well, what's in this paper, but really, it's maybe we could learn more. So we went, this was during COVID, and we collected 37 patients. And it was wonderful to, finally we had Zoom. I mean, we didn't have that really before. So that allowed me to connect with families in Australia, the UK, as well as the US. And I met a couple families at a playground in Carmel where I live, and that was fun. And then I thought, oh my gosh, I think this is too much for me. So one of my colleagues, Monica Wojcik, and I were talking at the David Smith meetings, and I said, Monica, do you want to work on this project with me? Because there are a lot of patients, and I got to get this thing off the ground, and it just seems like a lot. She said, sure. So, and she also filled in some of the blanks with getting these patients consented, which I had not done an IRB at my local institution for various reasons, including incredible hurdles that were insurmountable. So she did all that and wrote the paper, basically. We met, really, it was very fun. We met every month and talked about the progress of this project. So we collected these 37 individuals, 34 families, and I'll tell you a little bit about what we found. So you've seen this before. These are the variants in exons 5 and 6 that you've heard about. These are loss of function variants, and are pretty much localized to these areas. And someone asked today about their variant, and there are kids, several kids, who share the same variant, but they're not necessarily all that clinically similar. So the prenatal history, pretty unremarkable for most of these pregnancies, about what you'd expect in the general population. Some neonatal complications, one child had hypoglycemia, but nothing really striking. So usually the first signs that the parents noted was low tone, some feeding problems, and early on constipation. And these generally are what brought the child to medical attention. Now, just to kind of step back a little, or step forward a little bit, to say that it's much more common now to have an earlier diagnosis. And someone else mentioned that today, and it's because, first of all, insurance coverage for this testing has become much better. Also, this gene is now on a number of neurodevelopmental panels, which makes it easier for pediatricians to order this, or neurologists. And often parents are also advocating for early testing, and that certainly is appropriate. So you've heard a lot about the face, and you've seen a lot of these great kids around here. So the kids around here are the best teachers. I'll talk a little bit about the face, first of all, in infants and toddlers. And these are the faces of the kids we collected. And you can see there are marked similarities in a lot of them. So in the young child, what I've found is that the most characteristic face is between about 8, this is kind of a guess, but 18 months and 4 years. Before that, yes, for sure, in many of the kids, and after, yes, definitely for sure in some. But if you just look overall at the group, I'd say most characteristically between 18 months and 4 years. And what you're seeing, we've talked a lot about the wide mouth, and I think it's the smile. I think a lot of you would probably agree with that. They have a very characteristic smile. In the older child, it becomes a little more difficult to see some of the characteristic facial features. In some rather typical features, the typical kids, you can see these features. And again, the wide mouth, and you'll see, I'm going to mention this again, but you can see a lot of these kids wear glasses. And in fact, anyway, I'll talk more about that. Some of the children have a less typical face and do not really have the gestalt, so to speak, of some of the other more typical children. The face in adults also tends to be much more difficult to really describe or delineate, although I think with the tools that Jolene and Bert are working on, that may be much more possible. And of course, going back and getting earlier pictures would have been helpful in these adults. So face to gene, we put in 14 patients, and they came up with this composite, which I do think captures a lot of the features: the slightly deep-set eyes, the little tipped-up nose, the wide mouth, and they put in the glasses. So just to say that this new feature found, described by Jolene this morning, I went through my pictures, and actually there were a lot of kids who have this. And I think this would be hard to just see walking down the street or in a casual situation. But if you look very carefully at these two kids, you can see the little here's where a pointer would be helpful, but these little depressions right here, it's very subtle. It's not, you wouldn't really consider it abnormal. It's just a thing, a little teeny distinguishing thing. So most of the time, Janssen DeVries is brand new in a family. This is a change that occurs at the time of conception. But we have demonstrated now in at least 4 families known to us dominant inheritance, including where it's passed from a father to their child, so father to son. Many of these parents less affected than their child who led to the diagnosis, and that's kind of characteristic of many genetic syndromes. So here are some of the familial cases. In this case, to the family with 3 individuals, the grandmother also has this. I don't really know how I could figure out how old she is, but she would add to your natural history in terms of age. And they both have lived independently and raised kids, some affected, some, or only one affected. Well, I guess grandma had an affected daughter, and the daughter had an affected son. Hands and feet, there are very few actual measurements because that's difficult to get on Zoom. I see that someone recognizes their hands and feet. I warned Mom. This is a compilation of hands and feet. They're not all short, so this is a somewhat variable feature. Now the measurements, not terribly, in general, I would say these kids tend to be shorter, and you can see that here with the height, but there are not a lot that are extremely short. I mean, this is not a form of say, dwarfism or a skeletal dysplasia per se. It's not a bone problem. And head circumference a little lower than average, weight a little lower, but still kind of within the normal range, not spectacularly different. Now, growth hormone has been discussed a lot, and my ideas about this have somewhat changed over the last 4 or 5 years as we've been working with this. You can see here I have 2 kids who are on growth hormone. The one on the left has a really poor response to growth hormone over a long period of time. I really don't know why they're continuing it. The other has done beautifully on growth hormone. So in talking to our pediatric endocrinologist, she said that she felt that kids with this condition who are at -2 standard deviations or below, that she would consider growth hormone, maybe without provocative testing, which was, now I don't take that as the God's truth, but this was just a comment that I pass on to you that it may be worth discussing with your endocrinologist, because putting them through these growth hormone stim tests is kind of a deal for kids who really don't like needles. So development. So you've heard some of this already. Median age of walking is about 25 months, but it's variable. And remember, our sample size is not that huge. Age of first words, about 12 months to very, very late. That's a real outlier, though. That would be very uncommon. Wide range of cognitive outcomes, and I think we don't have the full picture. In Bert's original cohort, there was a child with an IQ of 109, I believe, and then someone today said that they had a very high IQ child. So I think this is quite variable. 18 patients, or about 25%, had an autistic spectrum disorder, many with anxiety, and many with hypersociality. And all of you have observed that during this meeting. I mean, I don't think I need to tell you about this. So in adults, they've had limited work, and I'm talking here about the ones where this is inherited, not so much about the cohort, but the affected parents had had limited work experience, but one completed high school, and 2 affected mothers run their households, and 1 is very proficient with the internet. Now, I don't think I even need to tell this group about the issues that are common. ADHD, hypersociality, no sense of danger, everyone's their friend, anxiety, very common, sensitivity to noise, and then we already mentioned autism. In the older kids, a range of issues. Behavioral issues continue to be somewhat common, but several adults have jobs with supervision. Several live semi-independently with some outside supervision. But for some, GI issues and migraine persist. Some of the other issues become less prevalent, such as the constipation. So I think that this is going to be dealt with by others, so I'm not going to deal too much with management. I think you all have talked about it quite a bit already. So the GI concerns are certainly significant. Reflux in a large number, G-tube feeding can happen, but it's not terribly common. And then these unexplained vomiting issues. I think this is underdiagnosed. Only in our series, only 6 have been diagnosed with cyclic vomiting syndrome, but it's just that it wasn't labeled. And I already mentioned that the constipation tends to improve with age and is very common. So, and here I just reviewed the cyclic vomiting and the triggers for cyclic vomiting, which I think you're going to hear more about. Excitement, change in routine, like going on a trip, going on an airplane, being tired. The parent group reported these episodes triggered by anesthesia, which is not in the literature to my knowledge, and then light and sound sensitivity. And this paper came out from the Italian group based on a questionnaire through the parent network. Moving on to vision problems, very, very common. Farsightedness, nearsightedness, cross eyes, many, I think most wear glasses. If I can go back here. So this little guy in the black glasses, he's in the optometry shop looking at glasses. I love this picture. So the constipation can be resistant to the usual measures, and routine metabolic studies have been negative in most, but I decided to, in collaboration with a biochemical geneticist, Richard Kelly, to look at one of my kids who has severe constipation. And we did find some minor abnormalities, including a low citric acid level. I then studied another kid, and he was normal. So I'm not really sure whether to go on with this or whether, but it seems like there might be something more going on with some of these kids who have severe constipation. So I think this may be worth more. I just am not quite sure based on the fact that my last child that I tested was normal. The parent group looked at the incidence of seizures, and they found that most had no seizures, but there were 4 kids who'd had multiple seizures and 2 kids that had just a couple. I don't think this is terribly common, but it's there. Another thing to mention is there are just structural defects are very rare, but there are now at least 2 kids with congenital heart disease. There have been 3 kids reported who've had an unusual and distressing syndrome of developmental deterioration, usually following an illness, with obsessive compulsive disorder, loss of some milestones, increased urinary frequency, and loss of previous skills with kind of slow recovery. This is a really complicated area. Dr. Lockman's been really interested in this. And the current theory, and because this kind of problem occurs in other genetic syndromes, and we've seen it more often than I'd like, frankly. But it suggests that it's genes and environment that might predispose to something like this. Overall, I think this is quite uncommon, and I wouldn't be worried about it too much, but I think it's important to have it on the radar. And these are 2 kids who have these issues and are both here and better. These are anecdotal reports, and you have to just take it with a grain of salt. One child had a serious disorder that led to him not surviving. I don't really think it's related to this gene. There's 1 incidence of thyroid cancer and an anecdotal report from the UK of a child with neuroblastoma. But this, again, kind of non-confirmed, no medical records, that kind of thing. So the take-home messages really are that these are kids that you know what their problems are. Hypotonia, constipation, a very characteristic face, growth hormone deficiency in some, and I don't think we have the total frequency. Hypersociality and anxiety, cyclic vomiting, and which often kind of morphs into, in the older child, into migraine. And then we know that it can be inherited, so that if kids reproduce, they are going to have a 50% chance of transmitting this to their kids. So I think in general the future is very bright. Look at this organization and how wonderful it is. These kids are worth your efforts. All the research you're going to hear about holds so much promise. And many of these problems do seem to resolve over time. And I think that the outlook for supervised independence is really good for many, many of these children. So the many clinical collaborators, this was I wasn't here, but you can see Bert and some of the kids you'll recognize. And I want to thank this phenomenal support group. Did I finish on time? I did.
We have time for questions. We're changing the show a little bit. So I need a runner for the mics
Really?
for questions.
I talked fast.
Should they come? The mics are back here, Kara.
Wait, somebody asked a question. I didn't hear it.
So we have on the program, you will see a video of Dr. Lockman. He couldn't be here in person. We are going to post that. We were going to show it here as a part of our program, but since we're running short on time, we're going to give that to you to do as homework. You will have it available on the YouTube channel with all of the videos that we recorded here today. It'll be available on our JWS YouTube, and we'll post the link in the Team Reach app after, so you'll have access to that. But for sake of time right now, we're going to give some opportunity for questions while Dr. Curry is here with us, so we can pick her brain, and then we'll still have our break at the assigned time.
Thanks.
Is this working? Okay. I wanted to hear more about the growth hormone. You said that your thoughts had changed on that. Our daughter, Sophia, has been on it for about 6 months. She did have a STEM test and failed it miserably. So we just kind of wanted to hear how your perception has changed, just if you could elaborate on that a little bit more.
Sure. Well, I think originally I was thinking that we should not be using this unless a child had a positive growth hormone STEM test. And as I mentioned, that's kind of a lot for a kid to go through. And so I was talking about my most recent patient who is going to go on growth hormone and showing our pediatric endocrinologist his growth chart. And she said, oh yeah, I think we wouldn't even really need a stim test in this kid because just look at this and we know what he has. So that's kind of how I've evolved. But still, I think you don't want to just put the kid on it because you don't know what the growth pattern is going to be. So you want to see what the growth trajectory is going to be over time. Does that help?
Yeah, I know that with Prader-Willi syndrome, which I think is called out in one of the papers, we have some friends whose daughter has that, and they've said that the research is showing to do additional growth hormone, like more aggressive. Are you familiar with
Yes,
that at
of
all?
course, of course. So, Prader-Willi, there have been several rationales for Prader-Willi and growth hormone. One is to increase muscle bulk and also to improve weight control because they're overweight, and to tangentially to improve growth. Now, the reasons are really kind of different in Prader-Willi. They're more related to overweight and severe hypotonia, which tends to be more significant than in Janssen DeVries. That would be my impression. So it took the journey to get growth hormone approved for Prader-Willi was a very long one. And it took multiple studies to prove that that would be efficacious for kids with Prader-Willi. I don't have a strong feeling about that in Janssen DeVries. Partly, I just don't know. Bert, do you have a thought about that?
I agree.
Okay. Yeah, so I would say follow the child, look at the growth chart, work with your endocrinologist, but I think it's different than Prader-Willi.
So my son, Noah, started growth hormone probably about 2 years ago. I believe we actually kind of discussed it prior to that time, and I had thought about doing it even earlier. The difference I have with Noah as compared to a lot of other people is I have a control because he's a twin, and so he has a fraternal sibling that does not have the syndrome. And so I could tell the differences in height and all of the other things. Having put Noah on growth hormone, initially they just did kind of like a growth hormone spot check, and that was not negative. So we did proceed with the stim testing, and he was found to be grossly negative. Since then, he's had, I believe, somewhere ranging between a 46 to a 64% increase, and he's now considered within the normal height range for his age. They follow him very closely. Endocrine does the bone health test with his hands, and then they adjust his growth hormone based on his labs. But a few of the changes I saw with that is just his overall body tone and ability to have more stamina in his day-to-day events was so much more significant since we started the growth hormone. But as I mentioned, it's a huge commitment. And so for Noah, he does the daily shots, but it's kind of like a kid being on insulin that has to take it at a young age. It's a very, very small needle, and he's grown very used to it. He would like to give himself his own shot. I don't quite trust him with that pen needle yet, but he understands, and it's just become a part of our routine.
I remember talking about this really early on with you and just saying, okay, well, we don't quite have the studies. And I still think like, well, you had a very positive growth hormone stim test, so there you go. Yes.
I just wanted to add to that, as far as the growth hormone, we were in the same boat when Daniel was 2. We started the growth hormones at that time. He had a really profound stim test as well. But later on, when you step back, of course, at that time, we felt he needs to grow. He needs to look normal within his, peer group. But standing back now, knowing what we know now, I'm not sure that we would have made the same decision at that time, because there are some other things to consider with just physical ability. And it's like Dr. Perry said, if there's other things that are really profound as far as muscle tone or obesity that's going to be excessive, or those kind of reasons for growth hormone therapy, absolutely consider it in that light. But just to have him grow and be a normal height, which was what we decided, we would have made probably different choices now, just because of a 16-year-old body growing, being strong, being tall, and the mind of sometimes not matching that can be problematic. Also, sometimes it's almost a disadvantage for him to walk into a room and expect to be just like anyone else, because he looks like anyone else. But then, having to have that conversation before that people realize, okay, there's something here. So just to step back and look at the whole big picture. When you consider those things, to think about those things as well.
I had a question about the low citric acid as it relates to the constipation. How is that tested? And if it is because of that, how is that treated, if you know?
Okay, so you get a citric acid level. Blood? Yeah, it's blood. And you can treat it with a kind of a combo of tricitrates, it's called. I would do this only with a gastroenterologist.
I was just going to follow up with what Miranda said, and with Tammy, she did not do growth hormone. They did talk to my parents about it early on, and it was so untested and there wasn't a lot known about it that they decided that they didn't want to move forward with it. And I can tell you, being at this perspective on this end of it, we appreciate her height. We feel like she's perfect as she is. And again, for the same thing, when she walks into a room, she looks like herself. And so I think that has helped us a little bit on that end of expectations being a little different than they might have if, she had looked like a neurotypical person of that size.
One tip I have for any of those that have kids that might be going in for labs, you may be able to talk to your doctor, and if they typically draw from the AC or a different area, our doctor has given us a small gel of EMLA, and you can put that on at home with a little Tegaderm over it. It makes it so that the child doesn't feel that poke, and I think it helps to, over time, decrease the anxiety that they have associated with those appointments and those needle sticks, or if you are going to go in and do a stim test. So it might be worth asking for. It's something that you just put on about a half hour before the appointment, and it helps take away a lot of that anxiety.
Very good tip.
One of the things that I looked into, and I think it's so good to have open-mindedness. I appreciate both sides of what anybody decides, because ultimately it's everybody's own individual decision. So I don't think that there's a right or wrong for absolutely anybody in regards to what you decide to do, because everybody's just trying to use the knowledge they have to maybe make the most informed choice. And like I said, there's no right or wrong. When I looked into some research, one of the things that compelled me to consider it a little bit further was that there's some research out there that state that children that do use growth hormone maybe have a little bit more advancement in their speech and cognitive abilities as compared to those that don't get growth hormone in some of these syndromes. So that was a little bit of a push to maybe try for that. But also, again, then it might end up being one of those situations where he's going to look like a relatively normal child, but still have other impairments. So maybe to that point, it will be a disadvantage. I guess it's all just kind of just trying to do your best and pick the best for the time and moment.
So on that note, what been talking about, I have a spray that I use, and my mom holds my head for doctors, for, it's a can, it's for it immediately. It's so your children does not feel, or little ones don't feel it, not at all. Yeah. So they don't feel the needle or something like that. I've been through so many of them. With that feeling, I do not want this. This, I can do blood work with it. I can do dentist appointments with it. I can do everything. I strongly agree with that too.
Thank you.
Okay, sorry.
Sorry, I have a question from another UK family that asked me to bring it today, and they were asking about teeth, and whether there was any, asking whether there was any sort of links with teeth, not in terms of dental hygiene, but whether there was any problems, and a common theme with problems with teeth and tooth decay and needing fillings and all of those sorts of things.
That's a really good question, and I don't know. I think that's something to be asked, and maybe. Oh, sure, yes. With cyclic vomiting, that of course is going to increase dental problems because your acid is being exposed to the teeth, etc.
And then also things like overcrowding and things like that of teeth.
You know, I don't have a whole lot of information on that.
My son is 9 years old. We are considering maybe in 2 months giving him a growth hormone, but some doctors and some studies say that giving growth hormone might raise the risk of getting cancer. Is that true?
I think growth hormones have been used so widely that I really think those risks, if they exist, are extremely low. I would never say never because it wouldn't be wise, but I think very, very low.
Thank you.
Thank you all.
Can I have one more question?
Sure.
I would love to hear if you have any thoughts on, you mentioned heart diseases, because my son is 19 and he had a severe episode of how do you say it again? I had it there. Pericarditis.
Pericarditis,
Yeah.
okay. So when I mentioned the heart disease, I was thinking of congenital heart disease, you know, where the heart is not formed properly. I don't know about an association with pericarditis. You know, things can happen to kids with syndromes as well as typical kids.
Yes.
So I don't know.
No, but that's actually 2 years ago. We were supposed to come to the conference, and he was 7 days in intensive care because of that, because it was a lot of liquid that had accumulated. But that is also, it can be, you know, from different things as well. But I just wanted to know if there was any kind of relation with
I
that
don't know
type
of any
heart.
other kids with that.
Good, thank you.